Hi, everybody. Welcome to our MVC post-discharge follow-up work group for July. My name is Rachel, and I am an MVC site engagement coordinator. And we are happy to be facilitating this work group for you today. Here is our agenda for today. We're going to go through our housekeeping and P4P credit reminders. Following that, we will have a presentation that myself and Janet, our data analyst, will be presenting on the MVC follow-up push report that came out in April earlier this year. And then following the presentation, we will have a brief interactive activity that will hopefully go very smoothly. And then we'll follow that with some discussion time or answer any questions you all might have. And then we'll close it out with some MVC upcoming events and updates. All right, for our housekeeping items, just a reminder that this session is being recorded. So the slides and recording will be shared with attendees following the work group in an email. Also a reminder to have your microphone muted during the presentation. This helps reduce any background noise that might occur. And then if you have questions throughout the presentation, feel free to put them in the chat. We will definitely look at those once the presentation portion is completed. For our P4P participating sites, we just want to remind you that we do want you to have active participation. So any interactive activities, wink, wink, or questions you might have, please put that in our chat. We love to hear from you all, and our members love hearing from you too. And then at the end of the work group, we will have a post-work group survey that will be posted in the chat. And then we will also share that in the email following the work group for folks that need to fill the survey out for engagement points. Reminder to please put one hospital for your site that you'd like to earn the points. And let us know if you have any questions about that. And moving on, we're going to introduce our presenters. So today we have Janet Zhang, who is one of our MVC data analysts, and she did a lot of hard work on this follow-up push report that came out. So she's going to be helping walk through the report today from the data analyst perspective. And then myself, Rachel, I am one of the site engagement coordinators with MVC, and I am going to be kind of joining Janet in breaking down the report and hopefully giving you guys some actionable takeaways that you can take back and look at your report with. All right, so kicking it off, MVC follow-up report, a walkthrough. Janet, I'm going to pass the baton over to you.
Sure. Thank you, Rachel. Good afternoon, everyone, and thank you for joining today. My name is Janet. I am a data analyst with MVC, and I'm very excited to be here to walk through the new follow-up report with you all today. MVC recently developed this report to better understand the post-discharge follow-up pattern, and our goal today is to use this report as an example to showcase how MVC is reporting post-discharge follow-up rates, and then we will use some examples from the report to summarize the key takeaways. The report that we're going to see today are based on the MVC 30-day inpatient episodes for adult patients hospitalized for 4 conditions. They are CHF, COPD, pneumonia, and sepsis. The reporting period includes the index admission between January 1st, 2023 to December 21st, 2024 for all Blues and Medicare patients. Medicaid episodes are capped at September 30th of 2024. Within all of those episodes, the report evaluates whether the patients received at least one follow-up visit after their discharge. Follow-up can be either in person or remote, and we assess the follow-up occurred within 3 days, 7 days, and 14 days after discharge. Visits that occurred after a readmission, a inpatient procedure, emergency department visit, skilled nursing facility visit, or inpatient rehabilitation visits are excluded and not counted as eligible follow-up. These inclusion and exclusion criteria were designed to align with the follow-up value metric in MVC portion of BCBSM P4P program, so that the findings from this report can help you better understand your performance on these P4P value metrics and identify opportunities for improvement. Using all of those follow-up rates, we developed 2 reports at hospitals and system levels. Both of those reports are based on the exactly same underlying patient cohort. Those versions that you're going to see today are not specific to any individual MVC hospital, but instead, it is a very closely matched, blinded version of what actually the report looks like. All right, without further ado, let me go ahead and share the report. Can everyone see the report right now? All right, let's start with the system level report. The system level report is intended to help the hospitals and system understand how their follow-up performance varies or not varies across hospital within the same health system. We basically have already covered all of the information here in the cover letter in the presentation slides, so I'm going to skip that and start with the page following that. This page shows you the follow-up rate for all of the hospitals within your system, separated by the conditions included in this report. Depending on the condition, the value metrics uses either a 7-day or a 14-day follow-up rate. And the cell content over here is the 14-day or 7-day follow-up rate for each cross tabulation. This table also provides you with your hospital number. This number is assigned to each and every hospital in this report and will be carried out throughout the report. The following pages are organized by the 4 conditions that we mentioned. We're only going to take the first condition on the first page as an example for today's walkthrough. The layout of the pages were identical for all those conditions. It's just they're using different data specifically for those conditions. For each eligible condition, the report will begin with a caterpillar plot showing you your hospital level follow-up rate across the MVC membership. All of those hospitals highlighted are under the exact same system. We also provided you with the system average and MVC all average follow-up rate as a comparison. This caterpillar plot allows us to quickly see whether your hospitals are clustered together or relatively spread out, meaning there will be a little bit more variations within your hospital in your system. Below this caterpillar plot is it's a bar chart that's showing you the 3-day, 7-day, 14-day follow-up rate for all of your hospitals in your system. I think this figure is one of the most useful part of the system report because it moves the conversation from one single metric and shows you kind of the trajectory of the follow-up rates. For example, a hospital may have relatively low 7-day follow-up rate, but a much more stronger 14-day follow-up rate, which could suggest that follow-up is happening, but it's just not as quick as we would want to. So at the system level, the report is very useful for identifying variations across hospital in the system, and it can help system answer a few questions, such as, are there certain hospitals that consistently performing better in all of those conditions compared to other hospitals in the system? So maybe there is best practice that we want to share system-wide. Following the system level report, let's take one step further by focusing one single hospital. We're going to take Hospital 1 here as an example. What we're looking at here is the hospital level version of the follow-up report. The first page is also the cover letter, which convey the similar information that we have talked about in the presentation slides. So I'm going to skip the cover letter, and we will see a very similar table on the page after that. This table is showing you the socio-demographic overview of the patient cohort for each condition under this hospital. This table includes age, sex, race and ethnicity, most common comorbidities, and a few zip code level measures. Those are community index value, a few non-medical driver of health. Those are household income, SNAP utilization, vehicle, and home ownership. The reason why we're providing you with all of those contexts is because we know follow-up performance does not happen in a vacuum. The hospital's ability to achieve the timely follow-up can be influenced by the characteristics and the need of your patients. So the purpose of this section is to give the hospital more context that may help you tailor your improvement efforts. Below the table 1, we will find the condition-specific page that is similar to the system-level report, but it provides more details. At the top of each condition-specific page is also a caterpillar plot. This figure compares the hospital's follow-up rate with the peer hospital for 3-day, 7-day, and 14-day follow-up rates, while showing you the ranking of your hospital among all of the MVC membership. These differences in ranking at different time points can help you highlight where delay may be in follow-up and where there may be opportunities to improve the timeliness. The middle figure here compares the average 30-day risk-adjusted, price-standardized episode payments for patients who did and did not receive a follow-up within the condition-specific value metric window. We compare your hospital's payment with your region and MVC all to help you determine what is the impact of follow-up on total episode payment and how that is comparing to your peers. The final figure on the condition page looks at the follow-up rates by payer. This helps the hospital understand whether the follow-up performance looks similar across all payer population or whether certain groups stands out or may face greater barriers. For example, a hospital might see a stronger follow-up rate among Medicare Advantage patients, but lower rates among Medicaid or dual-eligible patients. This kind of pattern can help generate very useful operational questions around scheduling access and care management. All right, this actually concludes our report walkthrough. I'm going to pass it back to Rachel for some key takeaways and next steps.
Thanks, Janet. That was great.
Thank you.
Okay. Gonna move my slides ahead. All right, so where do we go from here? We're going to be breaking down the report and hopefully developing some useful, actionable takeaways. Looking at the Hospital 1 blinded report, we're going to be using this as a single site example, and hopefully it will be a helpful guide for you when you're looking at your site's own report. And if you have your follow-up report easily accessible, you might want to have that open and look at it while we're talking through this. You might be able to take some notes and find some great ideas. So focusing on this single site blinded report, the following data takeaways seem to be the most relevant for addressing any potential QI work. Looking at the single site report, we noticed that the follow-up rates appear lower than most other MVC hospitals across all 4 conditions. This was especially true in the early follow-up and in sepsis follow-up overall, having a bigger gap. Number 2, it was noticed that sepsis and COPD have the most room for improvement, particularly in the 7-day and 14-day follow-up. And sepsis had the lowest 14-day follow-up, and COPD had lower early follow-up, plus higher episode payments when the patient had no follow-up, which don't worry, we're going to dive into that shortly. And then also one thing to note was that the Medicaid-only and dual-eligible patients had much lower follow-up rates than the other payers. So we are going to be walking through each of these areas in the following slides. All right. So for the first part of the report we're going to look at is the all payers combined, and it's comparing the single site to the MVC general acute care hospital cohort. If you're having difficulty seeing these graphs, you can feel free to zoom in by clicking on the screen of the slide and then holding down control, and you can zoom in with your mouse scroll button. I do realize that the font and everything is pretty tiny. But this was just a really nice way to kind of visualize the different conditions all lined up for the same graph. So this one is depicting the 3-day, 7-day, and 14-day follow-up rate among patients hospitalized. And these are by days to follow up. And it's a ranking, so it's showing the site compared to all the other sites in the cohort. So the goal for this particular graph for sites would be as far to the right on this graph as possible. That would mean that you have, the higher follow-up rates. So the farther left you are, the more potential there is for improvement in your follow-up rates. And the different colors that are being shown, the dark blue is the 3-day follow-up, the gray is the 7-day follow-up, and the goldish brown color is the 14-day follow-up. As you can see here, it's pretty obvious looking at this that the sepsis condition has the lowest follow-up rate compared to the other areas. COPD, as we mentioned before, has the lowest early follow-up, 3-day follow-up. And then most of them are kind of either halfway or lower, on each of the graphs. So that's just one way that you can look at these to kind of help you start focusing in on a group of patients. My little annotation. Okay, and I'm gonna move this out of here so you guys don't have to see that. All right, so that's one thing to kind of consider when you're looking at these graphs. I think, Janet, you had something to add on this one as well.
Yeah. So on the screen, we are seeing 4 conditions that is included in this report, and those 4 conditions are the MVC portion of BCBSM P4P program for the follow-up metrics. The reason why we have all those 4 condition breakout is to kind of offer you information on those value metric and see where can be areas of improvement. So that you don't really have to tackle all 4 of the conditions all at once, and you can compare in your report which conditions will need more attention or effort. And also the rankings of, so like the 3 caterpillar plot that we're seeing in each figure is showing you the rankings at each different time point for your follow-up. And that is kind of pointing to how timely your follow-up is happening. And that can suggest some improvements as well.
Awesome, thanks, Janet. Okay, I'm going to move on to our next slide, an example. This slide is, you can see a clear difference between the Blues, Medicare, and Medicaid and dual eligible patient populations in the follow-up care. Use my little tool again here. So as you can see in these sections, these are significantly lower than the Blues or Medicare. And then for this report in particular, we pinpointed that the sepsis and the COPD were the lowest out of the conditions overall for the follow-up in days there. So that's just another way that you can kind of start narrowing it down even more is by the payer. And we listed the percentages over here on the left side, so it's a little easier to see. And let me see what else I need to say here. And I think, Janet, you had a little bit to add on this one as well.
Yeah, so in your hospital level report, you will see exactly the same figure being replicated for each condition. And you will notice some of the figure only have 4 clusters, some of them have a little bit more. The reason why we omit some of the payer for some conditions in your report is because those payer have very little number of episodes that we have found during this time period, and it didn't surpass our suppression criteria. Sometimes when the episode volume is really low, we were going to see a weird number, or the number is driven high by only a few episodes. So we choose to omit that. That's one of the reasons why the figure can differ. The other thing is you are the experts in your negotiation and care management realm. We want to provide you this by payer because we have received feedback on that payer can be a very influential factors in patients' care management, and those rates can help you identify which payer population needs a little bit more attention and target your interventions on.
Awesome. Thanks, Janet.
Mhm.
All right, we're going to move on to the next portion. I wanted to stop here and just have a little reminder before we look at the next slide, because it does have to do with episode payment. And we always like to remind everyone that MVC's data that focuses on episode payment and spending is not a dollar-to-dollar comparison for sites. We like to think of it more of a unit of utilization of services. So just so everyone is clear on that as we move into the next part. All right, so this is the other graph that we shared in the follow-up push report. This is showing the average 30-day risk-adjusted price standardized total episode payment among patients hospitalized with the 14-day follow-up status. And I went ahead and I pulled out the two significant conditions in this report to kind of show why you would want to focus on them in particular. So we looked at COPD and sepsis again, noting that the COPD 14-day follow-up, when patients have a 14-day follow-up, their utilization of services is less than if the patient has no follow-up within the 14 days. It's a few $1,000s on our graph, but that does show an amount of utilization that's not occurring when they do have that follow-up. So it's just a way to kind of point you into the direction of where you might want to start looking if you have these areas where patients are not following up and you know that, okay, that means they're going to have a higher utilization of services overall because of that. So it's our biggest opportunity for improvement and to improve the follow-up for that patient demographic. And then just a reminder that we do like to tell our members to be careful when you're using the payment data for making decisions at your facility because it doesn't necessarily indicate lower spending with the follow-up care, that no follow-up care is causing the issue. It's just one area that you can look into to see if there's some room for improvement. But as we've seen in other previous slides, we're starting to see a bit of a pattern with these two conditions. Lower follow-up rates and utilization of services is higher, costs more when the patient does not have a timely follow-up. So leading into Janet has a few more things to add to this one.
Yeah, just like Rachel said, the dollar amount over here is not actual dollars that we're spending, and this figure definitely is not suggesting that follow-up is costly and adds up the total episode payments or the otherwise. What we were trying to indicate through this figure is that the follow-up visits may have downstream effect on the utilization for patients' 30-day episodes. That's why we are seeing the patterns of the differences between the patients who have or not having a follow-up visits. So I kind of want everyone to think about having follow-up as an impact on the patient's total episodes, so like 30-day episodes, not just as a single standing events that happen post-discharge.
Right. Perfect. Thank you so much, Janet. All right, so we are going to move forward to our suggested action items. So because sepsis has the lowest 14-day follow-up rate and COPD had a low early follow-up plus higher episode payments when follow-up was absent, these are some good first targets that sites could focus on if this were your report. So focusing on COPD, it could look like the following. You might want to try scheduling a primary care or pulmonology follow-up before the patient is discharged. You could consider confirming medication, such as inhaler access, affordability, and the patient's ability to use the medication, like their technique for the inhaler. And then, if appropriate, you could also refer patients to a smoking cessation program. There could be a screening for pulmonary rehab need, and then also documenting an action plan for patients and or their family and caregivers. These are all recommended COPD actions that are aligned with the GOLD COPD guidance, ATS pulmonary rehab recommendations, and AHRQ discharge planning best practices. And then on the right side here is just kind of a visual example of a goal that you could set. So in that Hospital One report, they had a 33% rate for COPD 7-day follow-up, and a good goal for them initially would be to try and reach 43% follow-up rate within that time frame in about 6 months. All right, moving on to the next section. This one is focusing on sepsis. Some of the takeaway action items that you could look at for this area, for this report, would be to schedule a primary care follow-up within the 7 to 14 days before the patient discharges. And there's a similar theme there. Include a medication review and make sure the patient is very aware of the sepsis warning signs once they're home, so they know when they need to call and go back in. You can also have care management follow up with high-risk sepsis survivors, and also flag patients that are discharged to home without any home health as high priority follow-ups. So if you know they're not going to see anybody right away, make sure they're on your list. These sepsis discharge and transition of care recommendations are coming from the Michigan Hospital Medicine Safety Consortium, HMS, which I'm sure many of you are very familiar with. And they have a lot of great resources for sepsis care and quality improvement on their website. All right. What we like to do as well is make sure to tell our members to make sure you're validating before you're initiating. It's always great to utilize MVC claims data in conjunction with your own internal clinical data. One example that I can share is that you can pull, and this would be specifically to this report, but you could pull a recent sample of your CHF, COPD, pneumonia, and sepsis discharges from your EHR, and then look at these several different areas that could give you some good information on where to focus your target QI work. So there's several here, like appointments scheduled before discharge, the visit type they had, how many readmissions or ED visits there were, no-show rates, etc., which I'm sure many of you are very familiar with, but sometimes it's helpful to have it all listed out. And then this, just a reminder that MVC data only includes billable claims, so there could be much more information on the clinical side that can help be supported by the claims data. And this can just help identify practical issues that can be solved, such as follow-up visits occurring but not being captured correctly, or patients being instructed to call but not successfully scheduling their appointments, patients that are being discharged on the weekend, having lower follow-up rates, or certain units or services lacking a standard workflow that could easily be improved. So if you have any more questions about the figures or want to see something in more depth, we recommend reaching out to us and maybe requesting a custom report. Our push reports are usually pretty broad in scope. So if there's something that you think might be a little bit more detail oriented at your site or system that you want to look at, please reach out and let us know. We're happy to talk about it. All right, so that is going to lead us into our interactive activity. And bear with me, this is my first time using the technology, and I really hope that it'll be as fun as I think it will be. This is a kind of a screen to give you instructions on how to get it set up. We're going to be using our Zoom Annotate tool. And to access that, you will be wanting to go up to the top tabs at the top of your Zoom meeting window. And the three little dots will allow you to open this drop down where you can select Annotate. And then you should have a toolbar that appears that looks like this. And then once we're on the slide where we're going to be annotating, you'll be able to click on the check mark, which is the stamp button. Or you can use the pencil and draw, or you can type with text. And then you can also modify the color if you feel like. But yeah, so we're going to get you guys all set up with the Annotate tool. If you can't get it to work for whatever reason or don't feel comfortable trying to do it, please feel free to put stuff in the chat. But ideally, on the next slide, I'd love to have lots of little doodles and words pop up. All right. Moving on to the next slide. Ooh, oh, somebody already drew. Don't worry, I can clear it. Okay, so using the blinded report that we just discussed as a scenario, if you found in your follow-up report that the 7 and 14-day follow-up rates for sepsis patients are much lower than the other conditions, and patients who do not have follow-up care have higher utilization of services, which of the above would be your top priority as an action item? And all I want you to do is you can do a little check mark, or you can do a circle or a smiley face, whatever you feel like you want to do. And you should be able to do it right on the screen. There you go. I'll give folks like a minute to do that. And some folks aren't seeing the 3 dots. Okay, that's not a problem. If you can't see the dots, then you can go ahead and put your answer in the chat. Oh,
Sorry, I had a hard time finding the 3 dots too, but what helped me was I was looking for the tab where it says Rachel Folks Screen. And then once I saw those words, so if you see the words where it says Rachel Folks Screen, and then the 3 dots should be right next to that. If you're not seeing that, then happy to just have you put your 2 cents in the chat, just kind of trying a fun and different way of getting folks to react.
perfect. Love it. Loving it. It looks like we have a lot of folks choosing the builded post-discharge outreach workflow for high-risk patients. Very nice. Probably give it another 10 to 20 seconds. Very good. And then also creating a standard process for scheduling the first follow-up before discharge is another popular one. Excellent. All right. So I'm going to go ahead and I'm going to save this lovely picture. Okay. Beautiful. All right. So I captured all your beautiful artwork. Thank you so much for participating in this and kind of experimenting with me to see how this worked. Really appreciate it. So our next portion we're going to head into is our discussion and question time. Kind of want to know what your thoughts are on why you chose this as your top priority or the first thing that you would, focus on if you were in this situation with this report. Feel free to unmute or you can write it in the chat. I'm going to move us over. Actually, I'm going to leave it here just while we're talking about this. So we have the words there. All right. Move my toolbars out of the way here. Okay, it looks like there's a lot popping in the chat here. So we've got, let's see, increasing early follow-up, build post-discharge outreach. And then Jana's asking how many folks have an outreach workflow already, and if so, is it a call, patient portal app, communication, static materials, etc. And then let's see. It looks like Allie has, we utilize nurses that are on light duty, making that make the phone calls. That's a great idea. Let me see if anybody has their hands up. Don't see any hands. Feel free to raise your hand if you want to chime in with your reasoning. Catherine says some of these might actually occur simultaneously, but building the outreach seems the top priority. Excellent. All right. Thanks, Catherine. People really like that middle one.
I wanted to just ask a quick question because
Yeah.
I can't see who just said it, but there was somebody that said they were calling, and a lot of times people aren't answering the phone, which I think is common. And I'm just going to speak from the fact of having young adult children. They don't answer the phone, but for anybody really but me is what they tell me. So I'm curious about if people have tried. I know Michigan Medicine has for some certain service lines like a chat text feature that when you have an upcoming procedure or something like that, you can do it. Is anybody else that's on the call right now using those kinds of aspects of technology to follow up with patients afterwards rather than calling? And if so, can you speak at all about how you got that implemented? And by the way, I'm honored that my children answer the phone for me.
And then Catherine did note that for their system, Corewall system, coordinating with ambulatory would be a huge undertaking. And yes, I could see that. You guys have lots of sites. All right. Gina has a question. How do hospitals collaborate with PCPs who are also charged with conducting the post-discharge follow-up? Whoop, it hopped away here. Follow-up to avoid readmission and close quality gaps. There's a lot of duplication. It's a good question. If anybody has an answer for that or an idea, feel free to share. And then Diane says, we struggle with scheduling the first appointment after discharge because many of our community providers are part of a different physician organization and want their own case management to arrange those appointments. Has anyone else experienced this and have any success collaborating with a competing PO? That is interesting, yes. I do know that, and I'm not sure that it's exactly the same situation, but my Michigan has done a lot of work with their care coordinating center, kind of taking on the gap between the hospital discharge and then the patient getting to their first like primary care physician appointment. And they've seen a lot of good outcomes for their patients, being able to help them make that transition. So I do I have seen that, and that's actually one of our other work groups from earlier in the year that I'll be sharing a link for you guys later as well. Let's see. Having some similar issues with the physician organization difficulty. Does anyone have a solution for lack of transportation issues? I do know that there's been a lot of work from some sites, especially rural sites, working with like remote patient monitoring or even doing like virtual visits or phone calls. But if there's anything else that's a little different, folks feel free to pipe up or put it in the chat. All right. So Megan notes that the physician organization lets them set up appointments, but private docs don't. Hoping once they get Epic going, that will help. And then let's see. One of the biggest enablers, this is Mary, of my facility would be inhaler education and assessment. We use NEBS for inpatient meds. I don't see many outpatient encounter notes that document this, even doing targeted teach to goal. Interesting. With inhaler training, Megan worked with a local HHC and they added it to all the visits and trained all their staff. It was huge. That's a great point, Megan. Thank you. All right. Seems like the chat is winding down. Let me get this out of here. Okay. All right. So we had some great points everybody made. Thank you so much. Oop, I got to clear my annotation here. There we go. All right, so we kind of did our discussion Q&A a little bit. Does anybody have any questions about the reports in particular, or any feedback or any ideas that you'd like to share for future reports? Seems like maybe there are no questions or feedback for today. If you do end up having an idea or feedback, you can feel free to send it over to us.
Rachel, this is Catherine from Corwell.
Yeah, hey, Catherine.
Hi, I just want to say I appreciate these work groups where we get the opportunity to go through some of the reports. I'd like to see if we could have one in the future that kind of worked with how we can utilize the benchmarking reports to drive quality. And Jana answered some of my questions in the chat, but maybe how we can utilize the MVC report, because I hear all the time like, oh, the data is older, the data is older, but it's used more. I mean, as I get more experienced in MVC, I'm learning it's more for benchmarking, it's more for trending, and maybe how different healthcare systems can pair it with other CQI data or other, I don't know, dashboards within your electronic medical record. And maybe this is something like to take offline, or if there's others on the call that also feel that would be helpful. But I would love to use more of the MVC reports to get it up to our leadership and quality, and kind of use some of that data that you were talking about, like the episode spending and things like that. And how can we kind of pair it with the work we're already doing for, HMS sepsis or BMC2. And I think in the QI survey that we completed, it might have been a month ago now or a few weeks ago, it had asked, where do you, what are the other CQIs that you're aware of that MVC aligns with? And I looked at that list, I thought, oh my gosh, is it more than HMS sepsis and, BMC2? Like, I didn't realize that there was other alignment. So I don't know if that would be something to take offline for like our particular sites, or if there's other people on the call that would be interested in that. But I would just love to be able to push some of these reports up to leadership and have it be a little more meaningful for them.
Yeah. Yeah, I really appreciate that. That's a really good point, because I'm sure you're not the only one who feels that
Yeah.
way.
I mean, they
So
want like a lot of the, leadership that we're working with, they want the data from yesterday, not like 6 or 18 months
right.
ago.
Yeah,
But
it's a
I think
different,
it is still great for episode spending and benchmarking and comparing ourselves to other health systems in the state. But how can we kind of create a report or create some sort of leadership summary that would elevate our MVC reports, if that makes sense?
yeah, absolutely. I think that's a great point. I really
Right.
appreciate you sharing that.
Yeah, thanks, Catherine. And I'm actually going to use that as an opportunity to shamelessly shout out our site coordinator education program, because as you work through that program, I think, Catherine, you've talked with Emily quite a bit.
Yes.
Part of the fourth module, when you get to that point, is really
Okay.
about us trying to help. And so the more people that we get involved in that site coordinator education program, that's the more that we have this bank to pull from, where we can pair you guys up with one another and do this real, like, because these work groups, they're, like you said, they're great. We have a big group. We know, though, that people sometimes are hesitant to speak up in a big group, or it can be
Yes.
difficult, but kind of pairing folks up with one another who are working on similar projects or have had success in similar areas is really where
Okay.
we are trying to get to with that program. So, like I said, shameless shout out for that, because I really want to get everybody involved in a way that we can be more proactive with pairing people up together.
And
If that
I
makes
will
sense.
second that shout out. If anyone hasn't signed up for it yet with Emily, like I missed it the first round. I was like, I am so busy. I don't have time for that. Oh my gosh, it was so wonderful. Emily does a fantastic job. I don't think she could get me off the call because I just kept getting ideas as I was talking to her. So if anyone's out there as a site coordinator, or even if I just sign up for it, give it a try, because I think there's a lot of untapped resources in MVC that we can be bringing forward to make it more visible to leadership.
Yeah. And that said, we actually are doubling our capacity to be able to do that, because Rachel's going to start doing them as well. When we started this program, it was sort of a pilot just to see how much interest we
Okay.
had and how many
Yeah.
people would want to do this. And we are gaining a lot of interest. We're seeing a lot of benefits. So very soon, some of you will be meeting with Rachel as well. And the two of them have worked very closely to develop this program together.
Oh, I'm glad to hear that. It's a great, again, it was such a great opportunity, and I learned a lot during the first module for sure.
Good.
That's
Then we
wonderful.
can start
Thanks for
doing some
sharing.
better peer learning.
All right. Wonderful. All right. Anybody else? Before we move on, we're getting a little close on our time. No? Okay. All right. Well, thank you so much for everyone for putting your comments in the chat and participating in my interactive activity. Really appreciate that, and I hope you had a good time with that as well. We're going to move on to our MVC. Oh, actually, I have a few other slides just to share really quick. For like an FYI, we do have work group resources to utilize if, this presentation in particular kind of sparked that, like, oh, I could do this, but I need this information. These are just a few of our past post-discharge follow-up work groups. They are available on YouTube. I did link them on the slide with a brief description. So if you find that you want to follow up and watch one of these or all of them, that's up to you. You'll be able to do that easily through the slide, or you can go to our YouTube channel, and they're all available there as well. And then I also cited all of the references I used for the the report breakdown, where we kind of developed the different actionable takeaways. So if you want any of those are available. So our next upcoming work groups, we have our preoperative testing work group on Tuesday, August 11th. And that will be presented by Henry Ford Health Genesis. They're going to be talking about their preoperative testing initiative. And then following that will be our Health in Action work group on Thursday, August 27th. And this will be DMC Detroit Receiving Hospital presenting on their stroke program, which should be of interest to many people. Some of our upcoming events, just a reminder for our MVC Fall Collaborative Wide Meeting, we are still accepting presentation proposals. They are due by next week, Tuesday, July 28th. The link for sending in a presentation proposal form is here on the slide. It is also on the website, and it will be in the email I send out. We're looking for poster presenters and I believe breakout presenters as well. So please send in your ideas. The focus for this fall collaborative wide meeting, we're looking for initiatives that have leveraged MVC data, i.e. like the push reports or customer reports, or even our registry reports, or insights that you've gained from best practice sharing at MVC events, like this work group. Or we are also looking for proposals that feature QI initiatives that leverage claims data for other aspects of planning, implementation, and evaluation. And then let's see, next is we actually also have a few other work groups I think this year we're looking for presenters for, so also consider that as an opportunity. Members love hearing from members, so we're always looking for folks to volunteer to present. And that is it for today. Thank you so much, everyone, for participating. The link for the post-work group survey is in the chat, and I will also send that in the email. Thanks, everyone.
Wait,
Oh,
sorry. I'm sorry. I'm going off script. I just wanted to promote a resource that was recently completed by partners of ours, the HBOM team. If your site has surgery service lines, which I'm assuming the majority of you do, they just finished creating a kind of standardized best practice teaching tool for post-surgery patient education around what to eat, how much to sleep, movement, tobacco cessation. It's a really nice website. I put it in the chat. It was developed in response to sites saying that they didn't really have nice materials to share. They were having to develop them themselves. So pass it around, within your institutions if it's helpful to leverage as an additional educational resource for your patients.
Thanks, Jana.
Great.
Will that be included in the follow-up email? Can you include that link as well?
Absolutely.
Okay. I'll copy, because if I copy it now, I know I have to hop to another meeting. I know I'm going to forget, but I think that will be a useful tool.
Absolutely. Yeah, I'll send that out for sure.
Thank you.
You're welcome. All right. Thanks, everyone.